Hi everyone, I'm Dr. James Januzzi, Associate Professor of Medicine at Harvard Medical School and Director of the Cardiac Intensive Care Unit at the Massachusetts General Hospital. I'm a heart failure cardiologist as well as an active clinician, and I do a whole lot of biomarker research. And because of this fact, I have the real fortunate opportunity to evaluate a number of novel biomarkers for the evaluation and management of patients with heart failure. And I'm very happy to be talking today with you about the measurement of ST2, a biomarker that I view to be among the most promising of all biomarkers currently available for the evaluation of patients with heart failure. Now, I'd like to give you some examples of patients that we've measured ST2 chronically over time, just to give you an idea of how the test behaves. This first case is an example of a patient with chronic heart failure enrolled into the PROTECT study with an ST2 measurement at baseline and then over approximately 8 visits. At the enrollment to the study, this person's ST2 value was a rather elevated 72, and over time, with therapeutic changes such as the addition of an aldosterone antagonist, as well as an increase in the aldo antagonist and the implantation of a cardiac resynchronization therapy device, we see a substantial fall in ST2 values in parallel with the benefits of these treatments. Interestingly, this patient developed an elevated serum potassium over time in response to the aldosterone antagonist, and in this setting, the aldosterone blocker was stopped. And we see a slight upturn in the ST2 value in the subsequent visits after the aldosterone antagonist was stopped. So it just shows this dynamic interplay between therapy and prognostic biomarker. Here's another patient with an elevated ST2 value at baseline. We were able to get some degree of control of the biomarker, and this was done with a number of different treatments, including adding a new diuretic and an increase in the diuretic intensity. We added a vasodilator in this patient, and then interestingly, this patient stopped their diuretics, and we see a rise in the ST2 concentration. We then restarted the diuretics, and the ST2 value fell. So this interplay, again, between therapies for heart failure and ST2 values identifies this really nice opportunity for physicians to not only stratify risk with ST2, but operationalize the values such that this biomarker provides actionable information for therapy changes. It's not just, hey, your patient's at high risk. It's, doctor, you must do something for your patient in order to reduce their risk. Another dramatic example is seen here. A patient with an elevated ST2 value at baseline, well over 100, which for someone who measures this test clinically, I can tell you, when I see a value of 100, I get very worried. And then at visit number 4, this patient's ST2 value rose to 500. This is a kind of concentration that we typically see in association with patients with cardiogenic shock, the likelihood for heart transplantation, and the need, as in this case, of being admitted to the hospital and to receive what we refer to as tailored heart failure therapy. And this is specifically achieved with invasive means with the high likelihood for progressing on to the need for mechanical cardiovascular support if it doesn't work. In this case, however, the tailored therapy did work, and we see the ST2 value not only fell back to the baseline value of 100, but actually fell even further after successful heart failure therapy guided by invasive hemodynamic monitoring. So a nice interplay between ST2, not only with drug therapy, but also with many of the more invasive or aggressive therapies that we give in the hospital. Lastly, this is another example of a patient we measured ST2 14 times over about a 1-year period. And in this setting, the patient had an aldosterone antagonist added, their diuretics increased, a vasodilator added. We started them on exercise therapy, and a nice gradual reduction in ST2 from 60 to about 35, which is our goal, right? We want to be at or below 35. But then what happened was this patient went to a baseball game here in Boston and had a salty meal at the baseball game. and decompensated their heart failure state. And in this setting, ST2 went from 30 up to 50, so near doubling of the concentration of ST2. This is a high-risk finding, and yet the patient only had mild symptoms. So the ST2 value is identifying a substantial risk that clinically I might not have been able to identify just with clinical means. So with aggressive adjustments in this gentleman's medical therapy, we were able to restabilize him both in terms of his mild symptoms, but very importantly, again, if you look at the concentrations of ST2 in this patient, over time, we were once again able to get his value down below 35. And this patient did remarkably well subsequently. So I hope I've made a compelling case for the value of ST2 in patients with symptomatic or so-called stage C heart failure. I'd like to extend this a little bit now because this is really the future. We know that ST2 is of value in those patients with symptomatic heart failure, but what's the future? Well, the future is to think about not only those patients with so-called stage A or at-risk heart failure, stage B, asymptomatic left ventricular dysfunction, but also those patients at the very end of the heart failure stages with the most advanced cases of heart failure. These are areas that are relatively understudied relative to heart failure biomarkers, partially because till recently there were no biomarkers that had sufficient value or power in terms of prognostication to be able to be used in the more subtle forms of heart failure, such as stage B or even the at-risk patients, while also providing prognostic value in the most advanced heart failure patients in whom the disarray biochemically is so significant that many other biomarkers are just elevated in a nonspecific way. As you can imagine, I'm bringing this up because ST2 has been now shown to be of value across all 4 stages of heart failure. Let's start with stage A heart failure. These are patients at risk for heart failure, representing by far the largest number of patients in the 4 stages of the American Heart Association staging classification. We looked at ST2 in the Framingham Heart Study, and among 3,500 patients with a number of potential cardiac risk factors that previously knocked out all other biomarkers that have been applied in this cohort with respect to the value to predict future cardiovascular disease. We showed that ST2 values not only survived adjustment through adjustment for a number of relevant covariates, it remained a powerful independent predictor of death, cardiovascular disease, and future heart failure over a mean follow-up of approximately a decade. So a value of ST2 over a 10-year follow-up could identify, depending on which quartile the patient fell in terms of their ST2 values, anywhere from a 2 to 3-fold risk for incident heart failure over a 10-year period. Very robust and provocative finding, because as we know that therapies for heart failure particularly reduce ST2 values, the real question now will be, in an apparently well patient, should we be making therapy adjustments to reduce their risk for future heart failure? It's a testable hypothesis. In patients with stage B heart failure, these are patients who have suffered a heart attack, a myocardial infarction, but who have not yet shown signs or symptoms of heart failure. ST2 values, when adjusted for troponin and for natriuretic peptides, allowed for reclassification of risk and independent prognostic value for predicting future death or heart failure onset. These are data from the Clarity TIMI 28 trial showing the likelihood for a cardiovascular disease event, including mortality, or heart failure in patients with stage B heart failure. Even more compelling, data from the Merlin TIMI 36 study showed that an elevated ST2, again over 35, identified patients at very high risk for incident heart failure over a relatively short period of time after myocardial infarction. These are very compelling data. and suggest that among patients presenting with myocardial infarction, above and beyond the usual tools that we use, including natriuretic peptides and troponins for stratifying risk, ST2 should be right in there in the multi-marker strategy approach that we use in these patients to particularly identify those patients in whom very aggressive anti-remodeling therapies to prevent incident heart failure would be justified. Importantly, when we think about what therapies we might choose, there are a number of candidates, one of which has actually been studied relative to the benefits of the drug with respect to ST2 values. Specifically, Robin Weir from John McMurray's group examined ST2 concentrations in patients after myocardial infarction, looked at their randomization scheme to either placebo or an aldosterone blocker known as eplerenone, and showed that those patients with an elevated ST2 value treated with placebo were more likely to suffer significant left ventricular remodeling and progression to heart failure, whereas those patients with an elevated ST2 value treated with eplerenone had no such remodeling and progression to heart failure, suggesting that ST2 can identify, in particular, those patients in whom guided therapy with an aldosterone blocker following myocardial infarction would be most justified. Lastly, those patients at very advanced heart failure, those patients who have terrible upregulation of multiple biomarkers. If you measure a natriuretic peptide in patients with end-stage heart failure, typically they're so dramatically elevated, it's hard to sort out one patient from another. In contrast, we recently showed that among an ICU-based population of patients with advanced heart failure, ST2, but no other marker, including NT-proBNP, highly sensitive troponin, or measures of renal function, only ST2 was able to identify those patients who are likely to die or require a heart transplantation within 90 days after its measurement. So very importantly, even in the most advanced population of patients that we see in the hospital with severe heart failure, this blood test was able to identify the higher risk patients while offering reassuring information about those patients who were not likely to require advanced heart failure management. So again, one can envision utilizing ST2 to stratify patients to more aggressive treatment strategies, including mechanical support or transplantation, while taking a reassuringly low ST2 value as a sign that these patients can be managed in a lesser aggressive posture. So from the at-risk patient to the end-stage patient, we can now easily measure ST2 values. And across this wide spectrum of heart failure severities, ST2 is among the strongest, if not the strongest, predictor of heart failure complications, adding to and frequently superseding the value of natriuretic peptides for this application. The dynamic change of ST2 in chronically followed patients affords extra added prognostic information, and indeed I measure ST2 at the Massachusetts General Hospital together with natriuretic peptides in all of my heart failure patients at each of their office visits, because I find that it does indeed add substantial information beyond the natriuretic peptides. This is important because not only does ST2 provide important prognostic information, but it affords interesting response to therapy information, as therapies with favorable effects on heart failure also have favorable effects on ST2, allowing us to more longitudinally monitor these patients. But I assure you, ladies and gentlemen, that this biomarker is here to stay and will be used in a wide range of patient types, heart failure as well as others. I'd like to thank you very much for your attention, and I hope you find this biomarker as compelling as we do at the Mass General Hospital.